Just making sure it is going. We are going live on YouTube, live from the new Cardiovascular Horizons Conference in New Orleans. And it looks like we are definitely live. Um, we're live here at the new Cardiovascular Horizons Conference in New Orleans, Louisiana. It's a gathering of doctors and industry where they talk about the advances in care for both vascular and cardiovascular, whether it's arteries or veins in your legs, in your heart, in your carotids, wherever they might be. It's your human superhighway, and anywhere they are, they're talking about them here. They're talking about how to get them open and how to maintain your blood flow, make sure there's no traffic on any of your roads or your detours. Dr. Michael Siah is here. He's a vascular surgeon at UT Southwest in Dallas, Texas. He's incredible. He's had several miracles with patients that have come his way from our organization, and within our organization, some patients who have found him on their own. And so we're going to hear from him. We're going to talk about all of the different advances that are really catching his eye right now, maybe some of the frustrations he has, things that, still some roads we still have to pave yet in the care for peripheral artery disease, it's those blocked arteries and mainly the legs. 3 in 5 people who suffer a heart attack have these blocked arteries in their legs. 1 in 10, I think it is, over the age of 50 has peripheral artery disease, 1 in 5 over age 60. And diabetics, 1 in 3 over age 50 has peripheral artery disease. So definitely worth hearing what the advances are in the treatments. So here at this event, you've been on podium. What was your topic that you discussed, and what were the takeaways that you hope that doctors are bringing back to help their patients with PAD?
So I had the opportunity to talk about practical applications of a clinical trial that was conducted not too long ago called the BEST CLI trial, and how it's affected my practice. And the reason why it's important is it was the highest level of evidence that we can create as physicians. So we randomize patients to either open surgery or an endovascular intervention. And this was all for patients who had wounds, had non-healing wounds or pain at rest. And what that trial found is there's certain patients that benefit more from bypass with using their own saphenous vein. And then if you don't have saphenous vein, the options available to you all work very well. But ultimately, like you alluded to, peripheral arterial disease, when people have wounds, it's a very challenging situation, not only for patients, but for physicians too, because it's a predictor of badness, whether that badness is amputation or cardiovascular related death.
Right. And when you have these patients that we're talking about with the BEST CLI trial, we're talking about patients with the most advanced stage of PAD. It's critical limb ischemia, or CLI, or CLTI, critical limb threatening ischemia, depending on who is describing it, but it's all pretty much the same thing. But in this BEST CLI trial, they, as you said, they were comparing endo versus the bypass. But in either case, it's literally not it's not a durable solution. These procedures, they're just trying to see which method is going to be the most practical to get you the most blood flow to get those wounds healed if you do have those wounds on your foot. And that's typically right when we're talking about treating these CLI patients, is to heal the wounds. But it's to heal the wounds to get you back on your feet, to walking, to grow your collateral vessels. So you're not expecting either of the procedures, whether it's bypass or whether it's endo, to be a durable solution. You're just trying to heal the wound to get a patient back on their feet. And I think it's important for them to understand, right?
I mean, absolutely. I think there's a big difference between open surgery and endovascular therapies, right? And endovascular therapy allows a patient to be taken care of expeditiously and sleep in their own bed that night. You get to go home. If you get a bypass, it means you're getting a big incision. It means you're going to spend some days in the hospital, and we have to worry about the surgical wounds we create healing too. That being said, the expectation, the data we have is, if you do a bypass with vein, it's probably going to stay open for a little longer than a stent in your SFA or a stent in your thigh. But not every patient can get that type of bypass. And, anecdotally, based on my experience, not a lot of patients that I see in my practice day to day have veins that can be used. In those situations, we rely really heavily on endovascular solutions. And then in some situations, we think about using alternative conduits like PTFE or a graft, or in even worse situations, we have to think about using cadaveric tissues, somebody else's vein, and using that to do a bypass, which in and of itself has its own shortcomings.
Fantastic. We had a question that came in earlier about endarterectomy. I can't remember who asked it, but they were asking, they're getting ready to have an endarterectomy actually on Friday, and they want to, they want you to go through the process. What can they expect from the procedure? What happens during the procedure? Why does a doctor do it?
So yeah, those are great questions to have, especially going into the actual operation. So the word endarterectomy to me is just a fancy way to say we're going to open up your blood vessel surgically, physically remove the plaque there, and then close the artery up, usually with something called bovine pericardium, which allows the artery to be larger than it was before you had the operation. So not only are we physically removing the plaque, but we're also making the artery slightly larger so that this disease process doesn't rapidly recur and cause symptoms again. So to do the operation, it's a type of operation that we do all over the body. We can do it in your carotid arteries in your neck. We do that to prevent your risk of stroke or to prevent stroke. We can do it in the aorta, although it's not as commonly performed there. But I think another more common location that it's performed is the common femoral artery, or the artery in your groin. So in the groin, when we do this, we make an incision, usually an up and down incision, and we deepen the incision to the level of the artery. We control the artery, meaning we put a vessel loop up high in your external iliac artery, it's the artery in your pelvis. We usually get control of the arteries in your groin, your superficial femoral artery, and your profundifemoris artery. And we do that so that when we clamp the artery or when we open the artery, there's no bleeding. So we do that so we can safely open up the artery and safely remove the plaque. Removing the plaque is pretty straightforward. I mean, this is an operation or type of operation that people have done the same way for probably 60 years. And, when something works really well, or people do the same thing for 60 years, it means the operation works pretty well. It's a very durable operation. And it's an operation that we like to do because we don't like to put stents in that location. We don't like to put stents in the groin because they're sort of
right at your bendy spot.
Exactly, right? So bendy spots, metal stents don't always perform the best there. So I think it's a tried and true operation. It's a great operation that can provide durable results.
I always like endo first, especially for patients, always try to go in with a wire, but Endart is still the gold standard for the common femoral artery. I mean, it's the one, it's pretty durable. Huh?
Yeah. I mean, people in Europe are actively doing clinical trials to look at endovascular solutions for the common femoral artery. And I think it is one of the semi-frontiers endovascular still has yet to conquer. That being said, some patients aren't the type of patient you want to take to the operating room for a femoral endarterectomy. I've had some pretty incredible results using intravascular lithotripsy of the common femoral artery. I can't say that I've never put a stent in the common femoral artery as well. There are a lot of unique situations that provide a good opportunity to use endo in the common femoral safely and durably.
Yeah, I mean, I've seen it. There was one situation where there were two different facilities within an hour of each other. And we were at one facility and I watched them use this one laser that used to be on the market, and it could cross CTOs without the need of a guide wire. And it went right through. It was amazing. The doctor went through this one full 100% occlusion, which is called a chronic total occlusion, or CTO. If you ever see that on your case notes, CTO is a 100% occlusion. And this was in the CFA. And it just literally like butter. It went right through. No stent was needed. It was just beautiful. Did a plain old balloon afterwards and low atmospheric pressure. And the patient walked out. I went to another facility about a week and a half later, and it was a university hospital. And they had a similar presentation of disease. So I'm thinking, oh my gosh, they're trying out this same laser. This is going to be great. Patient's going to walk out that day, easy breezy, no problem. They pumped in the contrast fluid, and then the doctor starts, taking off his stuff. And I said, hey, doc, do you mind if I do a quick interview with you? Like, I don't understand, because I was doing it as a journalist and following this. I said, I don't understand why I just saw this. And I showed him, and he's like, yeah, that's pretty similar. Yeah, And I said, well, why couldn't you do it? And he says, I'm sure the laser would have worked. The standard teaching protocols dictated that if you couldn't stent a particular artery, you couldn't treat it. And so they sent the patient for vascular evaluation for amputation, and she had her leg amputated.
Oh my gosh.
And this patient didn't know that literally just an hour, hour and a half away, another doctor didn't have that same philosophy, would have just taken that same laser, which he had done before, and opened up the vest, which is why I always tell patients, you always need to get a second opinion prior to any procedure to understand all options that might be available. Because as we're learning here, even at this conference, there are advances happening at the speed of light in PAD care. There's a lot of interest in especially below the knee vessels.
Yeah, I think it's sad to hear that somebody with common femoral artery disease ultimately went on to get an amputation. Because, you know, in my eyes, that's kind of like a never event in a patient with the appropriate risk to undergo surgery. Now, I'm kind of a little old school when it comes to the common femoral artery, but I also have the luxury of being a surgeon, being able to cut down if I do something endo and it some complications happen. And I think one of the complications from an endovascular approach for the common femoral artery is like if you cause a dissection or a tear in the artery, and that tear in the artery prohibits blood flow from getting down to the lower leg. I'm not entirely sure leaving that behind without a stent is going to do any patient any favors. So if you can't put a stent there, and you cause a dissection treating it, you probably need to call a surgeon quickly so that the patient doesn't get worse.
Yeah.
So you know, it's an unfortunate story. But you're absolutely right. There are a lot of new options and technologies available to help patients prevent amputation. That's what we all want.
And it's funny because it is the CFA. I didn't even think about that. So funny till now that I could have asked, why didn't you try an endarterectomy on that patient with the common femoral? That's so
I mean, it's just a tragedy. But I mean, you know, you've talked about this before. It's like there are a lot of patients in the United States of America who get amputations related to peripheral arterial disease, and they never are evaluated.
No.
They never get an ultrasound. They never get an angiogram. And I mean, that's why what you do is so important. Because you're raising awareness. Because all we can do is try to mitigate the badness that these people are
facing. Yeah. And I mean, and back to the endarterectomy to finish out that discussion with that one, we always, if there's a great surgeon, it's not that big of a recovery for the endart. I mean, you do need wound care.
Mm-hmm.
But it's really not that bad. Can you talk about the recovery process that she can expect and any complications that might arise that she should, after when she goes home, say, hey, you know what, red flag here. I need to go back.
Absolutely. So the worst thing about a femoral endarterectomy is the location of the incision you have to make, right? We have to make these incisions in the groin. It's an area where we're all a little doughy. It's an area where we sweat, and it's an area where incisions are prone to infection, right? That's by far the worst thing about that operation is the post-operative infectious risk of the incision. And the reason why it's problematic is because, like I said, when we close the artery, we generally put a prosthetic material to help make that artery bigger. And prosthetic infections are disastrous.
Mm-hmm.
No longer are we worried about the leg. We begin to get worried about the patient surviving. Right. So it's a real concern. So the biggest thing that I tell my patients after this operation is we have to make sure that incision heals perfectly. If there's redness, if there's drainage, don't wait a day, just call my office, right? Because the worst case scenario is we bring you into the hospital, we put you on antibiotics, we may have to clean up the incision. And that's something that can happen 1 in 5 times. You know, I'd rather catch it early than wait for a disaster to happen. So incision care, making sure your physician sees you 2 weeks after the operation, making sure you know that any drainage, any leaking, any bleeding from the incision is a cause for concern. And whenever I do these incisions, I always put a special dressing on called a wound vac or an incisional vac. So it may look like you've got a big incision, but it's a specialty tool that helps facilitate wound healing. And that's been shown to promote wound healing and mitigate the risk of wound breakdown.
So that's worth a patient actually asking the doctor. I imagine it's probably a 3-day stay in the hospital for something like that.
Sometimes it depends. I think that 3 to 4 days, sometimes 2 days, right? It depends on how much discomfort the patient has post-operatively. So I'm not in the interest of like rushing people out.
No.
But I think a nice average estimation would be 3 days.
And
2 to 3 days.
Make sure that you ask. Well, is a wound vac right for me to help with that incision afterwards? If not every doctor does that, it is worth asking if that's a possibility for you, right?
Yeah, and I think that I, I'm not sure if wound vacs are standard of care, but they're a huge, huge component of how I manage all my surgical incisions because I know they help.
And the incision is only what, 3 to 5 inches?
Depends on the level of disease, but yeah,
Yeah.
I think a 3 to 5 inch incision is pretty reasonable for that operation.
So, not as big, but it is more durable sometimes than the endovascular in those cases. But we still always suggest to a patient, hey, at least go in with a wire and balloon, at least take in IVUS, intravascular ultrasound, get a better idea of morphology of the plaque and what's happening. And at that point, decide whether or not an endarterectomy might be best for them is typically what we suggest. But honestly, in some of the places, some of the more rural areas, they don't even have an endovascular specialist, and we just got to go with the vascular surgeon. The vascular surgeon's available today. They're not going to be available for 3 weeks. We got to get this patient out of pain. I have no problem saying, hey, it's gold standard. Just get her done.
Yeah.
And that's one of the few.
Yeah, I would say that it is a safe operation. It's a well-studied operation. It's a great operation, especially considering we don't have the endo answer today.
No. Okay, great. I want to open it up to questions. I could sit here and talk to him all day. So, and I still have more questions to come. So if anyone wants to jump in, I believe, why don't we start with Mark Hammond? Mark, go ahead and unmute and meet Dr. Siah.
Yes, thank you, Kim, and nice to meet you, Dr. Siah. Thank you for taking the time today.
Happy
I'd
to
like
be here.
to ask you a question pertaining to my own diagnosis. Okay, I was diagnosed first in December with PAD based on ultrasound. Yesterday, I had the angiogram. So that was good and bad news. On the good side, my right common iliac artery was found to be partially blocked, 60 to 70%, successfully cleared with ballooning. However, the left common iliac artery was found to be a CTO, right? Chronic total occlusion. I spoke with Kim about this morning. My doctor didn't evaluate the trying to penetrate, as I understand it, based on his write-up. But based on the angiogram, the imaging, decided a fem bypass was going to be my best option. So what I'm interested in are there techniques, endovascular techniques, that might address my situation with the CTO and the left common iliac artery?
That's right there at the edge of the aorta.
Yeah, I mean,
Yeah.
the first question I've got for you is, how do you feel? What's going on with you?
I feel fine. I have no pain except when walking. I believe I must have developed PAD back in 2017 because that's when I began to experience deep pain in my left hip when walking, and it would disappear upon rest. I saw a number of specialists in orthopedics and spinal. X-rays were done, MRI was done. No one, unfortunately, ever came across or came up with the idea, maybe you have PAD. But otherwise, I
Yeah,
feel fine. There's no gangrene, there's no wounds, there's no pain at rest.
yeah. So I would say that your story is unfortunately a common story for patients who present with what we call as claudication. So the first thing I want to tell you is you're going to do fine. Claudication has very limited risk of ultimately leading to limb loss, right? The natural history of claudication, your symptoms, is not that concerning to me. But that's my
Okay.
perspective as a vascular surgeon. Kim might get upset with me telling you that.
No, actually,
Uh,
I mean, I think that because what questions did I ask you earlier? Mark, you asked me the question, well, do you think I'm going to be okay? What did I tell you?
Yes,
What did I ask you?
you said you'll be fine.
yeah,
Yep.
Mark, you're going to do fantastic.
I said, you just had your procedure yesterday. No matter what, you can't do anything for 2 weeks. And I said, do you have pain that's waking you up at night? Is your pain actually limiting your lifestyle? Can you do your basic tasks, at least for right now? And do you have wounds and gangrene? And he said, I'm like, you're
Yeah.
good for right now.
Yeah.
Well, it limits
I
my
certainly,
lifestyle
I,
for sure. At
I
this stage,
certainly would tell you a fem bypass is not an operation that's done for claudication, and it shouldn't be done for claudication. I would not recommend a fem bypass for claudication.
See,
I would not. And the reason why is while a fem is an option to get blood flow in the type of anatomy you have, a fem bypass requires the use of plastic or prosthetic material, and it also involves the violation of both groins, meaning two groin incisions. You know, the
Hmm.
one thing I was worried about for a femoral endarterectomy was one groin incision. Now you got two. And not only do you have two, but you have a plastic tube connecting the two groins. So any issue on one side can instantly become an issue on the other side in the short term. So
Hmm.
I would urge you not to get a fem for your symptoms. Now,
Okay.
your question was, are there endovascular strategies to do this? Absolutely. There's not really one way to do something endovascular, and that's kind of the beauty of it, and allows us all who do these interventions to exercise a little art, exercise a little artisanal flair when we do them,
Hmm.
because
I love that.
you can treat a blockage of the left common iliac from the arm. You can treat it from the left side. You can treat it from the right side. They have different tools that help us cross these blockages. They have different wires. They have different balloons. They have different stents. And the beautiful thing about it is if you get 10 different people, you could have 10 different solutions. The one solution that you have been offered is certainly not the solution I would recommend you pursue. So I think a
Okay.
second opinion would result in probably a lot of the same information I just imparted to you.
Hmm.
Um, but I'm not sure we're at the fem spot right now.
And then
Right.
that's where if it's literally and we've had people where it has been the last resort and there's a wound that literally won't heal and it would just bring a rush of blood flow soonest over there. But
Mhm.
even the doctor that did the one that we ended up saying, hey, to the patient, you got to go with this, just get her done because you're going to lose your leg if
Yeah.
you don't. Even the doctor was like, this is not going to last long. I'm just going to warn you. And what he told him is that legs mirror each other. And so what happens in one leg happens in the other. And so the problem that he expressed was that when the feeding leg goes down, both legs are going down, and you have both legs then at that point that are at risk of amputation. But he
Hmm.
said they were going to keep an eye on it and see where it went.
Yeah, and I
Hmm.
mean, like in those types of situations, they're more advanced open surgical procedures that we can talk about or we can recommend, but certainly right now that you don't need to have that conversation.
Except
Okay.
that I was always wondering, what about, and I know this is a much bigger procedure, but what if just an aortofemoral bypass?
Yeah,
Because those are pretty durable. Those are like 20 to 30 years we've seen.
yeah, aortobifemoral bypass. I'm not an advocate for aortounifems,
Yeah.
but aortobifemoral bypass is a maximally invasive operation that can be done within a 2 to 3 hours. I think is a reasonable amount of time to do one of them. Some people might be able to do them faster. Some people may take a little longer to do them. But it's a bigger stress on your heart. It's a more durable operation, but your risk of cardiac complications goes up, the risk of bleeding goes up, your hospital stay is going to increase. Um, and I'm not entirely sure it's an operation I'd offer for claudication either, right?
Yeah.
I think that there are lower hanging fruit that can provide you with a pretty durable outcome, addressing your symptoms, all with a needle and wire.
But even with lifestyle limiting claudications, there are significant risks when you perform endo with a patient with aortoiliac disease. Can you go through those and how to mitigate those risks and questions that patients should ask the doctor before a procedure like that?
Yeah. So my bias is I work at a university and I work in a big hospital.
Hmm.
And as a result, working in a big hospital, I have a lot more on the shelf readily available to take care of sort of whatever trundles in through the door. One of the biggest concerns I have when I treat iliac artery occlusions is, okay, I've gotten across the blockage. Now I need to open up the blockage. When you open up the blockage, you want to make sure that you don't tear or perforate the artery. Because if you tear the iliac artery, patients bleed.
Mhm.
And there's only one endovascular thing you can do in that situation, and that's use a covered stent. And there are a lot of different companies that make covered stents, and there are different types of covered stents. But the way you think about them is they're essentially PVC pipes that prevent blood from falling or going into that torn portion of the artery and out of
Right.
the blood vessel into the retroperitoneum. So arterial perforation is the biggest concern. So, I tell my fellows when they're graduating, they're going to go work in a private hospital. You don't do iliac arteries if you don't have covered stents, because you always want to be able to take care of patients and your complications. So that's the biggest concern I have.
And that's a good question. So if you are having something with the iliac, is ask your doctor, do you have these on hand? And I think
Right.
that's an important point.
I mean, that'll save your life.
Yeah.
My doctor's concern was potential injury to the aorta if he attempted to recanalize the iliac.
Recanalize, yeah.
Yeah, I mean, I'm not really sure what that injury would be, to be totally honest with you, because depending on, I mean, I wasn't there, I didn't see your angiogram.
Sure.
But I mean, iliac occlusions are a pretty commonly treated pathology. And people have been treating iliac occlusions endovascular since the 90s. So
Yeah.
I would say that I'm sure if you got an alternative opinion, they may tell you need aortobifem, but I guarantee you that most people would not recommend fem bypass
Understood.
for claudication.
Yeah.
Understood.
But if you are experiencing that, see how far you walk. You were saying that you're doing pretty good walking. See how far you can push it. See if you can develop those collateral vessels. Now that your right leg is doing fantastic,
Yep.
see if that'll help you to walk a little further, walk a little faster, and also start growing those collateral vessels. Because the longer you can put off a procedure, the better, because it is that revolving door, right? At some point, but you want to keep kicking the can down the road further and further, so that you're not constantly getting a procedure
Yeah,
done.
100%. I think that is the best advice you could get.
Right.
Well, thank you. I
Thank
learned
you
from
so
the
much,
best.
Dr. Siah.
Yeah, my pleasure.
Thank you, Mark. Really appreciate it. Are there other questions coming in from folks that are in the live studio audience that want to jump in? Barb or Charles or Alan, or if there's others that are on here, go ahead and
I
unmute.
actually
And you're
have a
welcome.
question.
Sure.
Hey, Doc.
Hey, Mr. Winters.
You've been talking to me for the last few times we've seen each other about the new stents that have just been approved by the FDA that are kind of absorbable. Do you
The
have any more
bioresorbable stent.
information on those?
I
Yeah.
love that you were talking to him about that. The bioabsorbable stents. Those are the ones by Abbott, right?
Yeah. So, I think the reason why I've talked to you about it is because, we had been limited by what we could offer you, the durability of what we've had on the market leaves some room to be desired. But, we're in this situation because you've had a bypass, you've had intervention, you're in a tough situation. So the bioresorbable stent is exciting because it provides us with an on-label tool to treat the arteries below the knee that works better than balloons and doesn't have the same limitations as the stents that we have available to us to treat arteries below the knees right now. So it's really exciting. We have access to it now at UT Southwestern, so it's something we have, and we can use it in the event that we need to. And I think it's going to help a lot of patients.
Can you describe the bioabsorbable stent and its mechanism of action so patients understand what makes it different?
Sure. So the bioresorbable stent is a technology, or it's bioresorbable scaffold, is a technology that's basically like a stent. However, instead of being made of metal, it's made of sort of combination of polymers that allow that structure to incorporate into the blood vessel wall over the course of months to years. So it's not something that goes away in 2 weeks. It's not something that goes away at 6 months. The process begins at around 6 months and goes on, depending on what type of patient you are and how your body reacts to it, over the course of 18 to 24 months. Now, in addition to being a structure that dissolves over time, it also has medications on it. These medications allow for a chemical treatment to mitigate the risk of disease progression, right? Because all the other therapies that we have available to us, whether they're balloons or stents, if they don't have the drugs that we like to use or drug elution, right? Everything we do is a mechanical treatment. We're basically just propping up the artery. And I think that's historically what we've only been able to do. But now with drug, we get to chemically treat the artery too. So it's a combination therapy. And I think that is going to help patients. Now, in the United States of America, this is the only drug-eluting technology we have on label to be used below the knee. We have a whole bunch of them for above the knee, but this is the only technology on label for below the knee.
And these drugs, when you're talking about slowing down the disease progression, you're talking about the healing response, right, in the body. A lot of that happens when you have trauma to the vessel,
Exactly,
every procedure.
Neointimal hyperplasia is the $5 way to say it, but it's our body's reaction to being treated. So almost damned if you do, damned if you don't.
Yeah.
But now we have better tools.
And it was already approved, right? There were a lot in Europe. They had.
So in Europe, they have a whole host of different technologies that we have available. And they're totally different tools. But yeah, the FDA approved the utilization of the scaffold after a successful clinical trial that we participated in, and the results of it were published in the New England Journal of Medicine. So I think it's a really exciting time as a physician, because I know that I've got new tools to help patients that have been validated.
There are a lot of doctors that don't believe in treating below the knee. Do you think that using, 2013 data, they say it's not worth it. They say it just increases the chance of amputation, just accelerates the process. Do you think that some of these new technologies, such as bioabsorbable stents, will actually offer a change of heart for some of these doctors that had refused prior?
I don't know. I mean, the idea that
It's not
opening
very
blood, I mean,
encouraging.
the idea of like not opening or dressing blood vessels below the knee, to me, is so preposterous of a headspace. It's contradictory to the way I believe and what I've seen in 10 years of being involved in vascular surgery. And if like, I'm not sure these people would respond to data, considering we've had data demonstrating that this stuff helps patients for a long time.
Right.
Right. I think the inspiring thing is I don't know any young physicians that think like that. So hopefully, as older physicians who believe like that retire, I'm not too sure. That sort of mentality will sort of fade away.
Well, it's interesting. We have a question that just came in earlier that are along those same lines. It was from a woman by the name of Cal. And Cal says, what's the difference between inline flow and outline flow? And why is it important? Because her doctor said that he got inline flow going great above the knee, did a small bypass, but then she still had pain afterwards. Weeks later, went back to the doctor, and the doctor said, well, you have great inline flow, but you have bad outflow, but there's nothing we can do about it. So go home and walk. And when you have too much pain, you can't deal with it anymore, we'll just go ahead and amputate.
Wow. I would say that when I use the term inline flow, I generally am describing drawing the line from your heart directly to your foot. That's what inline flow is. Any cutoff of blood flow above your foot inhibits you from having what I would describe as inline flow. So you can never say someone's got inline flow to their foot if they have blockages. So I think that's just my interpretation of what that is, right? So you can have inline flow to the level of the knee, right? Which to me means you have blockages below the knee, which affects the surgical decision-making or the endovascular therapeutic decision-making you have, because the goal is to get blood flow to the foot. I'm just a little confused.
I know. I mean, some of the things, a lot of doctors, Dr. Anita Duwa, she's on my board of directors. And for a long time, I would share with her some of these questions and things that were happening and things that doctors would say. And she's like, oh, that's just a one-off. That could, then the patient probably misunderstood. But like this one, she sent me the email. It was like, that is basically what the doctor said. There's nothing, it's an outflow problem and there's nothing we could do. But describing it as, above the knee looks great.
Yeah.
Not talking about anything below here.
Now that there's like,
no outflow.
People have desert feet, meaning that they're, for whatever reasons, due to their underlying comorbidities or exposures to toxic materials, if they grew up outside the United States, like they can have the obliteration of blood vessels below the ankle. Right? There's certain conditions like Berger's disease can cause that. And in those patients, they have no outflow. They can have inline flow to the level of the ankle, but then they have no blood flow in their foot. And these are the types of patients we talk about deep venous arterialization in. these are the type of patients we talk about putting nerve stimulators in to help promote just small blood vessel capacitance and carrying blood flow to the toes and stuff like that. And we talk about artist assist. There are a lot of different strategies we have, but yeah, it's just so tough to hear that patients are experiencing that. But at the same time, I'm not that surprised.
No, I mean, I hear it all the time that a patient will come to me and they'll say, I've just had a bypass. And I hear it more with the fem-pop or fem-tib bypasses. And within weeks, they'll say, you know what, I'm not getting any relief. And I explain to them that, well, you know, sometimes they fix the faucet, but if the plumbing below can't support that additional flow, then what are you going to do?
Yeah.
So thank you so much, Dr. Siah.
Yeah,
we really
thank you so
appreciate your
much.
time.
It
Thank
was
you for
great to be
answering
here.
our questions. We'll have you back again on another What's Up Doc.
Bye, guys.
Have a
Thank
great
you,
rest of the
Dr.
show.
Siah.
Thank you.
Thank you.
So that was Dr. Michael Siah. He is with UT Southwest in Dallas, Texas, and he is just an amazing up and coming vascular surgeon, definitely on the cutting edge. And so we'll get him on definitely again at some point, but we're here at the new Cardiovascular Horizons Conference in New Orleans, Louisiana. And so these doctors are just coming and going. They're being pulled in different directions. We even have others that are live on the podium right now. And I think that's where he's going. I think he's on the next session in 4 minutes. So he's really under the gun to run right now. So hopefully we'll get him back at some point. We do have more doctors lined up for tomorrow. I think tomorrow we're going to focus a lot on chronic venous insufficiency and efforts there as well. I see that Alan has a question. I'm not sure if I can answer it or if you want to wait for another doctor, Alan, but I'm happy to try and answer your question for you if you would like, or else we can go ahead and end this session. And we can reconvene tomorrow when we do have more doctors. Make sure if you are on our YouTube, make sure you do subscribe to our YouTube because then you'll get notified of all of our live events and you'll be able to participate and ask questions as well. Alan, did you want to jump in and ask a question?
Sure. It's about the profunda. As you know, and I've had a little bypass done on my profunda, and I'm a below knee amputee. And that's literally is the only vessel that's feeding my thigh and the rest of what's my residual limb.
Yeah, that's a really important vessel.
Right. What after this I couldn't get an endarterectomy. And what I'm wondering, because I've had so many surgeries in that area, that if it closes off the bypass, what options are there that are left?
Well, still a lot of times, Dr. Siah has left for right now. So that's something that I can write down and I'll post the doctors tomorrow as well to get a grander answer for you. But there are so many new endovascular options that are available. I'm seeing so much hope here at this conference. Doctors are talking about new tools, new techniques to get through blockages that they couldn't even get through even just a couple of years ago. And so it's pretty exciting to see the advances that are happening. And if one doctor can't do it, it's worth getting a second or third opinion from other doctors that might be participating in new trials or have a different access to a newer tool or newer technique. Different doctors go to different conferences. They are involved in different research studies. And so depending on where they go and who they're in contact with, sometimes depends on what they have access to. And so it's always important to make sure that you get multiple opinions before you have to take any drastic steps such as amputation, just to make sure that you do have the most cutting edge tools and techniques being used, or at least tried, to save the leg.
Thanks, Kim.
You're welcome. Well, I hope everyone has a great day, everyone. Join us again tomorrow, live from the new Cardiovascular Horizons Conference. As I said, we'll be lining up doctors for specific times. I believe we have a podiatrist, world-renowned podiatrist that is joining us tomorrow. So make sure you join. Bring every foot question you have to us. I hear he's just learned a little secret about becoming a little lighter on your feet and improving your circulation through dance, because 6 months ago he became a competitive dancer and he's learning something new that he's bringing to his practice and to all of his patients that is certainly helping them. So you don't want to miss his brand new trick up his sleeve tomorrow right here on the